Good morning. I'll be presenting the results of a systematic review of the literature aiming to estimate the costs incurred by people with pre-dementia or dementia and report them by disease stage and cost category. This work was conducted as part of an EU IMI funded project, the real-world outcomes across the Alzheimer's disease spectrum for better care, multimodal data access platform, or in short, roadmap. In this systematic review, we included studies published between January 2020 and May 2017, reporting costs incurred by people with either mild cognitive impairment, mild, moderate, or severe dementia. We extracted data on direct medical, direct non-medical, and informal care costs, and we then converted this cost to US dollars at 2016 prices using the purchasing power parity method. For studies reporting the setting in which people with dementia were living, we grouped the costs according to whether they were living in the community, in an institution, or in a mixed setting, which means that they could be living in the community or in an institution. We then estimated ratios of costs for people in the mild cognitive impairment, moderate and severe stages, compared to the mild stage by cost category and care setting. We identified and included 121 studies reporting costs for people with either mild cognitive impairment, mild, moderate, or severe dementia. Concerning direct medical costs for people with dementia, which include, for instance, inpatient hospital stays, outpatient consultations, medications, and primary care appointments, we found that direct medical costs represent only a small proportion of overall costs, and when compared to the mild dementia, as we can see in the graph, direct medical costs for moderate and severe dementia were not found to be significantly different between disease stages or between care settings. Direct non-medical costs, which include paid professional home care, residential and nursing home care, food delivery, daycare centers, etc., were the largest element of total costs for people living in an institution. We also found that these non-direct medical costs for people with dementia, initially living in the community, increased as disease severity worsened, as can be seen on the graph. In an institutional setting, on the other hand, these costs were equal for all disease stages. This might reflect a lack of granularity in data collected, for example, on the number of hours of care in institutions. In a mixed setting, whilst these non-medical costs increased with disease severity, they tapered off in more severe disease stages, probably due to the transfer from community care to institutional care. Finally, informal care costs, which consist of time spent by carers providing care to the person with dementia, were found to be the main cost component for people living in the community. These informal care costs in the community increased with increasing disease severity. In conclusion, we found that informal care costs and institutional costs account for the vast majority of overall costs for people with mild cognitive impairment or dementia. The important role of the carer in this disease is underlined in our findings by steadily increasing informal care costs in the community. However, we also found that not all care-related costs have been captured by most studies. For example, very few studies reported productivity losses or medical costs incurred by carer arising from caregiving activities. We also identified the lack of data in pre-dementia stages such as preclinical and prodromal Alzheimer's disease, which will be necessary to inform future health economic models.